Hi friends. I'm unable to see the chat. Hi Vishal. Hi Khan. Seriously, I wasn't expecting anyone. You know why? Because tomorrow is INICT and I thought all of you would be traveling for tomorrow's INICT. So I thought I'll be all alone. Hi Vishal. Sheikh. Hi, hi, hi. So happy to see many. Are you ready? How was the exam? Did you write the exam? There is some delay in me seeing your chat. How was the exam? Was it good? My question is about the Elite test series. I hope all of you have given the Elite test series. Today we'll be discussing the first two papers. Okay, paper 1 and paper 2. Amardeep, hi. Guys, are you not writing INICT tomorrow? There is a delay in me seeing your messages. So it was good, Suresh. Okay, okay. So let's start the discussion. Like I said, we'll be discussing the first two papers. Paper 1 was mainly about epidemiology and from the chapter screening. And no, I'm an FMG. That doesn't mean that, okay, you haven't passed FMG yet. No problem. Okay, let me complete what I said. So the first paper was on, epidemiology and screening. And the second paper, that means test series second was on 4 chapters actually. Demography, family planning, MCH and nutrition. So all the questions that I had given were typical prototype questions from which you can surely expect questions. Okay, so let's start. FMG. Okay, good, good. So the questions we discussed were actually common to FMG, then INICT, NEET, all these, like I said, were, prototype questions, which you just can't miss. Shall we start? Okay, so day one. This was the first question. An ancient country with population of 6 million people, 6,000 deaths occurred during the year 2005. These included 30,000 deaths from cholera in 1 lakh people who were sick with cholera. The cause-specific mortality rate and case fatality rate from cholera in 2005 are or were respectively. Any idea? Vishal, Suresh, Amardeep. Okay, I'm waiting for your answer. Yes, yes. Okay, let's see. Now, before going into the discussion, let me tell you, this is a typical type of questions that you can get from epidemiology. See, in epidemiology, we are mainly measuring 3 things, which are the mortality, that means number of people who died with the disease, morbidity, number of people who became morbid with the disease, and third is disability. So this question is regarding mortality rates. Okay, so let's see what are the mortality rates. Now the MCQ will be like this. You should be knowing the names of mortality rate. Okay, which are the all the following except one are the mortality rate, or all except or which of the following is not a mortality rate. Like that, you will be getting some question. So the mortality rates are mainly crude death rate, specific death rate, case fatality rate, and proportional mortality rate. So you have to remember these names are MCQs. Okay, these names are MCQ. Now, the formula of this is also an MCQ, and you will get some problem-based question like you have seen in the first question, using which you have to solve this question. Okay? Yes, yes. Poju, your answer is right. Now, let's see. So, these are the different types of mortality rate. Let's start with the first one, crude death rate. Crude. Now, nothing to mug up. This is very, very simple. Crude means it is non-specific. It only tells you out of 1,000 people living in an area, how many died, how many deaths occurred. So naturally, what will be the formula? Total number of deaths divided by mid-year population. That means number of people who were alive in that, or number of people who were there in that population at the middle of the year into 1,000. So that will tell you per 1,000 people in an area, how many deaths occurred. Okay, this is crude. Now, why do you say this is crude or non-specific? This will not give you any specific information like which disease is killing the people or which part is dying because of this disease. Is it killing small children or adults or elderly? Such information will not be given by crude death rate. So, we have the next one, as you can guess, specific death rate. So, this will specifically tell you which disease is killing the people or which part is dying. The other one only said out of 1,000 people, how many died. So, what will be the formula? I said the formula is also important. Number of deaths from a specific disease or occurring in a specific age group or in a specific sex group divided by media population into 1,000. Okay. Now, what is proportional mortality rate? I said third is proportional mortality rate. Now, what do you mean by proportion? Means a small portion out of the whole, right? Mortality means death. Then what would be proportional mortality rate? Very simple. Out of total deaths, because of all causes, what proportion or what part was constituted by one disease alone? So what will be the formula? Naturally, total number of deaths due to one disease divided by total number of deaths due to all causes into 100. So that will tell you out of total deaths, what percentage was contributed by one disease alone. Are you understanding? It's so simple. Now, I'm not stopping in between only because we don't have time. We have few questions to cover in next 2 hours. And the fourth is case fatality rate. Now, what is case fatality rate? Case means a disease. Fatality means death. See, you don't have to mug up at all. All these are self-explanatory. All these are taking, Sheikh, why they are taking middle year? Come on here. You have 1 year, right? So, you have to fix at some point regarding total, because number of people keep on changing every minute, every day, right? So, you have to fix somewhere. So, we are fixing it as middle of the year. That is the only reason. Okay. Case fatality rate means when you are calculating something for a year, you have to fix somewhere, and that somewhere is nothing but the middle of the year. Okay, Sheikh? Hope I'm... Yes, Amardeep. Yes, man, there is a lag. It's not my, it's not because of my technical problem, it's because of the YouTube. Okay. So, case fatality rate means, case means a disease. Fatality means death, right? So, as the name indicates, what would it be? Number of deaths due to one disease. So, how will you calculate that? Out of total people who got a disease, how many died? So, what will be the formula? Number of deaths due to a particular disease divided by number of cases or total people who got the disease into 100. Is that clear? Now, there are two very, very, very important MCQs from case fatality rate. Shall I tell you? Next MCQ is, case fatality rate will tell you the killing power of a disease. Do you agree with me? It is related to the virulence of the disease causing organism. Right? Both these are very important. NEET, INICT, then FMG questions. Okay, both these are very, very important. Case fatality rate gives you killing power of a disease, and it is related to the virulence of the disease causing organism. We know that case fatality rate of, say, Nipah, we know that case fatality rate is somewhere around, say, 80%. That means 80% of those who got the disease died. Hope you are with me. Okay. Now, moving on to the question. See, media population is given. This much data you will definitely get from the question. Total number of cholera cases, total number of deaths, and total number of cholera deaths. And you're asked to find out the second and the fourth. That means specific death rate and case fatality rate. So, what is specific death rate? Number of deaths from cholera divided by media population into 1,000. So, you'll get it as 30,000 divided by 6 lakh, 5 per 1,000. And case fatality rate, number of cholera cases, out of them, how many died? So, you will get it as 30%. So, like you have said, it is 5 by 1,000 and 30%. Okay. Will this video remain after live? Joshi, are you planning to skip it now? Don't skip. Sit there and watch. Okay. Next question. Okay. If an effective treatment is initiated and all other factors remain the same, which of the following is most likely to happen? What is the answer? If an effective treatment is initiated. Come on, come on, come on. Quick. When you start treatment, what happens? When you start treatment, the number of caseload will come down. That means people are getting cured and they do no more remain diseased, right? Now, what is by prevalence? What is prevalence? Prevalence means when you do a survey per 1,000 people, how many are having a disease? So, when you start treatment, what will happen to prevalence? The number of diseased people will come down and prevalence will decrease, right? Now, what about incidence? Incidence means number of new cases. See, treatment has nothing to do with number of new cases, right? So, what is the answer? Incidence will not change. Yes, incidence will not change. Treatment do not have any effect on incidence. Whereas prevalence will come down when you start an effective treatment. So, prevalence will not change? No, prevalence will change. Neither incidence, no, so that is not the answer. And this is the answer. Whereas, next MCQ is, which one affect incidence? Which one? Vishal? Two Vishals there. Okay. Which one will affect incidence? Screening. Do you agree with me, guys? When you screen, new cases will be found out. So that increases incidence. This increases incidence, right? Screening increases incidence, whereas treatment decreases prevalence. Both these are MCQs, guys. Keep it in your mind. Okay. So you can remember like IS. Okay. I is increased by S. Here, PT. Something like that. Okay. Shall I change the slide? Very good, very good. You guys know everything. A family consists of 2 parents and 6 children susceptible to measles. There occurs a primary case of measles and 3 secondary cases within a short period of time. Find out secondary attack rate. Okay, secondary attack rate. Now, what is secondary attack rate? First MCQ, what is the formula of secondary attack rate? Now, what is secondary attack rate? See, this picture itself is self-explanatory. First case got the disease. From the first case, others are getting infected. This is secondary attack rate. Okay. From the primary case, how many others got the disease? Okay. So the formula is, that is the first MCQ is formula. First MCQ is formula. What is the formula? Number of secondary cases divided by number of exposed susceptibles into 100. That means what percentage of those susceptibles who got exposed to the first or primary case got the disease. So this tells you about the communicability of the disease. Communicability. Is that clear? That is the next MCQ. This tells you about the communicability of the disease. Okay. Third MCQ. While calculating secondary attack rate, primary case should be excluded. That means the first person who got the disease should be excluded from both the numerator and denominator. So, secondary cases minus first case divided by number of exposed susceptibles minus the first case. Is that clear? All these are MCQs. Now, let's see the answer of this particular question. That is the next MCQ. That means you have to solve this question based on this formula. So, number of susceptibles. By the way, do you have an answer? Max. C. Okay, let's see. Let's see whether your answer is correct or not. Secondary attack rate. So, here, number of cases. Let me go back just. Okay. Number of secondary cases, there is no doubt. There are 3 secondary cases, right? Now, my question is, so in the numerator, it will be 3 only. In the denominator, what number you want to put? Say 6 or 8 or 7 or 5. What is it? The disease is measles, right? Measles is a childhood disease. It is considered as a childhood disease. So, usually parents are not susceptible. Only children. So, how many children? 6 children, of which 1 is a primary case. So, that should be excluded, right? So, number of susceptibles 6. 1 is a primary case, secondary case is 3. So 3 by 5 into 100, it is 60%. So the answer is A. Okay. Is it clear? Good, 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 Vishal. Guys, shall we move on to the next? Any restriction or lack of ability to perform an activity in a manner considered normal for a human being is called. It's there in the question. It's there in the question. See, lack of ability, inability to do something is known as disability, right? Inability to do a function is known as disability. Okay, so the answer is very good, disability. Now, from this question, I'm going to give you another 4 MCQs. Ready? There are 4 terms which are kind of similar. One is disease, then impairment, then disability, then handicap. Okay. Yes, Kriti. Welcome, Kriti. Bineem Shaji. Okay. Happy to see many. Now comes the MCQ. What do you mean by disease? Disease means, some malfunction. Okay. Now, for example, diabetes mellitus and polio. Now, disease leads to impairment. Now, what is impairment? Nothing to mug up. Impairment means, as the name indicates, what do you impaired? Impaired means you are losing, right? Impaired, word meaning is losing. What? Either an anatomical structure, as in the case of diabetes mellitus. Suppose the patient is undergoing amputation. Okay, either an anatomical structure or a physiological function, as in the case of polio. In polio, what is happening? Leg is there, but the patient is unable to, he is losing its function. Are you understanding? So, you are losing either an anatomical structure or a physiological function. Is that clear? Okay. I think you can see, I have some problem in using this gadget. I hope you are seeing it. Okay. Now, impairment leads to disability. Because of amputation, because of losing leg, the patient is unable to, disability means inability to do a routine function which is normal for that person's age and sex. Because of losing leg, the patient is unable to walk. That is disability, and that was the question. Okay. Now, what is handicap? Disability will lead to handicap. Okay. Handicap means because of this disability, the patient is unable to do a social role, which is normal for his age. Suppose he is the only breadwinner of the family. What is the social role expected out of him? He should be able to go for work and earn a livelihood, which he is unable to do because of handicap. Hope I am clear. Okay. So the next MCQ is, each of this is an MCQ, and next MCQ is, the order of these 4 are disease leading to impairment, leading to disability, leading to handicap. Am I clear? So these are, see, we have discussed many MCQs from this. All these are very important. Okay. All these are important MCQs. Now let's see what you want to tell me. Disturbance at cellular level. Yes, Bineem, you're right. Unable to perform socially, jobless. 1, 2, 3, 4. Good. Excellent. Okay. Shall I move on to the next? Which of the following is characteristic of a single exposure common vehicle outbreak? Like I said, all these are typical questions, and we will be discussing many MCQs from one question. I'm looking for your answer. Waiting for the answer. If when I get the first answer, I'll go to discussion part. Hurry, yaar, someone please. Uh-oh. Okay. Anyway, let's see the answer. Nobody's answering this. Single exposure common vehicle outbreak. The answer is All of the above. No, no, no. Not all of the above. Okay, let's see. The question is about epidemic curve. Okay, here the answer is explosive. Single exposure common vehicle outbreak means you have, this is an outbreak occurring from a common source and one time exposure. Best example would be, yes, best example would be, food poisoning. Food poisoning. Let it be from a marriage function or from a birthday party. Okay, and the question was from epidemic curve. So the first MCQ was, what is epidemic curve? Epidemic curve is a curve drawn with number of cases of disease along the y-axis and time along the x-axis like this. That's the first MCQ. Second, what you see here is the epidemic curve of a point source epidemic. Point source epidemic means, that was a question. Common source, one-time exposure. Okay, as in the case of, like I said, food poisoning. Okay. Now, in food poisoning, what is happening? Let it be, a birthday party. You are going to a birthday party. You are having food at, say, 7 p.m. You are having food at 7 p.m. It's a night party. Okay, birthday party. You're having food at 7 p.m. And the incubation period of the disease causing agent, say, it ranges from 2 hours to 24 hours. And the manifestation is in the form of severe vomiting and diarrhea. So what will happen? You'll have food at 7 p.m. After 2 hours, what will happen? The first person will develop disease. Then the second person will develop disease, right? That means that the first person, 9 p.m. Then 10 p.m. 11 p.m. Likewise, the number of cases will increase, right? And after that, by middle of the night, majority would have developed the disease, right? And then the number of cases will again come down, and after the next day, 7 p.m., not even a single person will develop disease because the maximum incubation period is 24 hours. So that explains the shape of the epidemic curve. Okay, so the points are, in point source epidemic curve, there is single peak. That is the next MCQ. There is only one peak and no secondary waves. Why? Because no case will develop after that incubation period. Okay, since all cases fall within one incubation period, that epidemic tends to be explosive. People will easily notice it. That is why you call it as explosive. So first MCQ, single peak. Second, no secondary wave. Third MCQ, it is explosive. So that was the answer. Is it clear? Yes. Next MCQ. Serial interval is time gap between. Because of this delay, would you mind if I directly go to the answer? Or you want me to wait? What do you want? Okay, the answer is time gap between primary and secondary case and not index and primary case. Okay, serial interval is the time gap between primary and secondary case. Now, ready for the next MCQ? What do you mean by primary case? What do you mean by primary case? Primary means, as the name indicates, primary means the first case. It's a very first case. Now, what is the importance of first case? The first case is, the problem with the first case is sometimes it may go unnoticed, right? You may not even realize that a case happened. Then what is index case? That is also the first case, but the first case that was noticed by the health system. Okay, is it clear? So first case, the very first case is known as primary. As the name indicates, see, there is nothing to mug up. As the name indicates, primary means first. So it's the first case. Index means, see, there is no need for confusion. What is the use of index finger? Are you seeing the index finger? Okay, you use index finger to show something, right? So that people can see it. So index case is the first case which was shown to everyone. Am I clear? It's very, very simple. Primary word meaning first. So very first case. Sometimes you may not realize that it had happened. Index means using index finger, it was shown. It was first noticed by the system. Is it clear? Okay. First noticed. Very good, Vishal. Please wait, ma'am. For what, Vishnu? To point at something. Clear. Good. Okay. I sometimes feel funny because of this, time gap. I'm asking something, you might be answering something which I asked earlier. So, okay. Okay. Change in occurrence of disease over long period of time are known as, you're all FMG, right? Then answer this. This question came almost, I would say some 10 times in FMG. What is the answer? Here I will not go to the discussion part until and unless you answer. Come on. Okay, direct answer it will. Okay, Bini. Okay. Okay, Vishal. You're right. Nigar, Ansari. No. Okay. Listen. The answer is secular trend. Okay. See, we have different types of time changes. Okay. Epidemic means, see, the time trend in disease can be divided into, you have short term. Short term. Short term means in a short period of time, you have an increase in number of cases, which is nothing but epidemic. Short term fluctuation is known as epidemic. This is the first MCQ. Long term means over a long period of time, you are getting an increase in number of cases. As in the case of lifestyle diseases, over the past, say, 2 or 3 decades, we have an increase in number of hypertension or diabetes. Okay, which is an example for secular trend. So long term is known as secular. That is the next MCQ. Long term is known as secular. Third MCQ. Seasonal trends and cyclical are known as periodic fluctuations. So these are the 3 types of time fluctuations in disease. It is periodic fluctuation. Am I clear? So you have short-term fluctuation, you have long-term fluctuation, and you have periodic fluctuation. These are the 3 types of fluctuations in time with regard to occurrence of disease. Short-term is known as epidemic, that is an MCQ. Long-term is also known as secular trend, a very, very commonly asked MCQ. And periodic fluctuation could be seasonal or cyclical. Is it clear? Good. Moving on to the next. All of the following are components of triangle of epidemiology except. The answer is none. The answer is none. So that brings you to the next question. If you had said time, you are wrong. See, you have something known as epidemiological triad, right? You have something known as epidemiological triad. Now, what is epidemiological triad? Tri means 3, right? So, in epidemiological triad, you have agent, host, and environment. This is epidemiological triad. Epidemiological triad. It has got agent, host, and environment. You're right. That is epidemiological triad. But, later on, we have found that mere presence of agent, host, and environment will not give disease unless you give sufficient time for its interaction. So, we have realized that time is also a component which can cause disease, or time is also a factor which determines the disease occurrence. So, along with triad, you have also added time into consideration, and you can call it as triad anymore. So you call it as triangle of epidemiology. Here the question was triangle of epidemiology, in which you have agent, host, environment, and time in the middle. So there are 4 factors in triangle of epidemiology, which is agent, host, and environment, along with time. So we have triad, which has only 3. This is triangle. It is known as triangle because this is how you depict it in a graph or in a picture. Agent, host, environment, and time in the middle. Is that clear? This is triangle of epidemiology. And this triangle of epidemiology is okay for a communicable disease. Whereas when it comes to a non-communicable disease, you don't have any single agent, right? Instead, you have risk factors. It is not a single person who is getting disease, but a group or population who is exposed to all these factors. Not just environment, but the cultural factors, so many things are there. So for NCD or for considering, this is okay. Epidemic triangle of epidemiology is okay for a communicable disease. For accommodating non-communicable disease, we have something known as advanced model of triangle of epidemiology. See, it is advanced model of triangle of epidemiology where, see, agent is replaced with causative factor. That is the next MCQ. And host is replaced with the whole population. And environment is replaced with environmental behavior, culture, physiological, ecological factors. And time is time only. So we have discussed 3 MCQs here. Okay. One is, agent is replaced by causative factor means beneath risk factors. Okay. So you have triad, epidemiological triad, then you have triangle of epidemiology, and C, you have advanced model of triangle of epidemiology. Each of this is an MCQ and the components are also MCQs. Okay. Shall we move on to the next? Next is from the chapter screening. A physical examination was used to screen for breast cancer in 2,500 women with biopsy-proven adenocarcinoma of breast and 5,000 age and race matched control women. The result of physical examination were positive in 1,000 cases and 800 control women. Sensitivity and positive predictive value of physical examination was respectively. What is the answer? Here I am directly going into the discussion. This is a question from screening. Okay. Now, in this particular question or in this scenario, you will have 2 tests. Okay. See, you will have 2 numbers, I would say. One, the number of diseased and non-diseased. Second, the number of test positives and test negatives. Okay. So here, what you are trying to do is, this, as I said, this is a question from the chapter screening. So here you have a screening test and you are trying to find out how good is your screening test in detecting the disease in the population. Are you with me? And how good is your test in doing its job is measured using certain parameters like sensitivity, specificity, positive predictive value, and negative predictive value. Are you with me? So, once you get this question, the first thing that you have to do is to draw a 2 into 2 table. And when you're drawing a 2 into 2 table, you have to correctly enter the test result and disease status. It is known as 2 into 2 table because you have 2 columns. These are the columns. Okay, you have 2 columns and you have 2 rows here. Is that clear? Next MCQ. Where will you write disease status and where will you write test status? So just remember, guys, I have a mnemonic. I can call it as a mnemonic. Just remember this. C, D. C means column. D means disease. That means along column, you always write disease. That is the next point that you have to keep in your mind. Okay. So along the column, you write disease, non-diseased. Same applies when you're calculating odds ratio. Okay. It's the same. And here you write test result. Positives, negatives. Okay. Next, let's see what were the data you had in that question. There the disease was breast cancer, right? And the screening was BSE. That means physical examination for breast self-examination or maybe done by a doctor. Anyway, it was physical examination. And It is clearly given in the question that you have 2,500 women with biopsy-proven carcinoma and 5,000 without disease. And when someone did physical examination, when one doctor did physical examination, out of this 2,500, 1,000 were found to be positive for physical examination, and out of this 5,000, 800 were found to be, out of 5,000 who did not have cancer, 800 were found to be positive for breast cancer by physical examination. This much you will get from the question, right? Now, what can you write here? 2,500 minus 1,000. Here, 5,000 minus 800. Right? Now, let's see what is sensitivity, specificity, positive predictive value, and negative predictive value. Very, very, very important. Okay? Sensitivity, specificity, positive predictive value, negative predictive value. Okay. Now, let me tell you one more thing. These are true positives, right? These are true negatives. What about these 800? They are false. What? Positives or negatives? They are. See, all these cells are named according to the test result. Okay, screening test result. Here, screening tests call them as positives, but they do not have the disease. They will be branded as positives because screening tests call them as positives, but they do not have the disease, so they are false positives. Okay, and here, screening tests call these 1,500 as negatives. So, they will be branded as negatives, but they do have the disease, so they are false negatives. This is also very, very important because I have seen questions in which, as per the gold standard test, patient has disease, but the screening test said the patient do not have the disease. So, it is false negative. Are you understanding? So, this understanding is very, very important. Now, let's see what is sensitivity, specificity, positive predictive value, and negative predictive value. Sensitivity means, listen very carefully. The ability of your screening test to detect all those who have the disease from the diseased population. So while calculating sensitivity, in the denominator, you put all those who have the disease. Out of them, how many were picked to be having the disease is sensitivity. Is that clear? Now, specificity means ability of your screening test to detect those who do not have the disease from the non-diseased population. So, while calculating specificity, in the denominator, you put all those who do not have the disease. Out of them, how many were correctly picked to be not having a disease by your test is specificity. Is that clear? Next, MCQ. What is positive predictive value? As the name indicates, positive predictive value means, see, your test has predicted a few to be positives. Test predicted these 1,800 to be positives, which include those who have the disease, true positives as well as false positives, right? Out of them, how many are actual positives? So, positive predictive value means, out of those who were predicted to be positive by the test, how many are actual positives? So, while calculating positive predictive value, in the denominator, you have to put all those who were predicted to be positive by the test. Out of them, how many are actual positives? So, that into 100 will be your positive predictive value. And negative predictive value, out of those who are predicted to be negative by the test, which include true negatives as well as false negatives. How many are actually not having the disease? Is it clear? So, it would be 4,200 divided by 5,700. So, sensitivity here would be, see, out of total deceased, how many were correctly picked to be not having disease by your test is sensitivity. So, are you with me, guys? Yes, which are true positives divided by, you're absolutely right. That is also an MCQ. See, given A, let me select some other color. I've written so much here that, okay. If this is A, this is B, this is C, and this is D. Sensitivity would be A divided by A plus C, right? That is also an MCQ. Specificity would be D divided by B plus D. Positive predictive value would be A divided by A plus B. Negative predictive value would be D divided by C plus D. Are you with me? See, in this particular table, we have discussed a lot of MCQs and I hope you guys are with me. Is that clear? Binith, Binim, Vishal. Yes, you are right. All of you are right. So the answer is A, 40% and 55%. Guys, is that clear? Please tell me. Is it clear? Because I don't want to take a risk in this particular question because it's so damn important. Is it clear? Please let me know whether you have understood how to do this. Okay. Okay, good, good, good. Okay, so very, very important question. Again, from the same question, but this is given, from the same chapter, but given in a different way. Another typical type of question that you can expect. A diagnostic test for a particular disease has a sensitivity of 0.9 and specificity of 0.9. A single test is applied to each subject in the population in which the disease population is 10%. What is the probability that a person positive to this test has the disease? Okay. By the way, first question, what are you asked to find out? Probability that a person positive to this test has the question means positive predictive value. So a definition of positive predictive values, I have told you what is positive predictive value, how to find a positive predictive value. Next MCQ is what is the definition of positive predictive value. Positive predictive value means probability that a person with positive result for actually having the disease. For example, if the positive predictive value of say let it be Mando. If the positive predictive, simply, I'm just putting some number, okay. Suppose the positive predictive value of Mando is, say, I'm saying 70%. And a person is found to be positive for Mando. That means, even though this person is found to be positive for Mando, he has only 70% chance for actually having the disease. Is that clear? So, positive predictive value means what is the probability that a person with positive result will be having the disease. Is that clear? So, here you are asked to find. So, this is also an MCQ. The definition of positive predictive value. What is the probability that a person who is positive for a test will be having the disease? Next, let's see how to find it out. Here, sensitivity is given. Specificity of the test is also given. 90%, 90%. Prevalence of the disease is also given. And you're asked to find out positive predictive value. This is the second type of question or second scenario that you can expect from this particular chapter. Now, let's see how to do this. Here it is said prevalence is 10%, right? That means if you take 100 people, how many will be having disease? 10 will be having disease and how many will not be having disease? 90 will not be having disease, right? Like this. See, if you take 100, 10 will be having disease and 90 will not be having disease. That is what you mean by prevalence of 10%, right? Now, sensitivity is 90%, specificity is also 90%. That means 90% of this 10 will be true positives, right? And 90% of this 90 will be true negatives, right? Okay, then what can you write here? 1. What can you write here? 1. Sorry, 9. Like this. Are you with me? Now, can't you find out positive predictive value? Positive predictive value is, when you simply look at this, you know positive predictive value is 50%, right? 9 divided by 80. So, the answer is 50%. Is it clear? Is it clear? Sonu, Vishal, Vinith, Vineem. Is it clear? So simple. So these are the only two type of problem-based questions that you can expect from this chapter. You will be directly given disease, non-disease, test results, and you will be asked to find out sensitivity, specificity, possibility value, negative predictive value. Okay. Second, you will be given something like what you are seeing here, and you will be asked to find out positive predictive value. Is that clear? Yes. Okay. Okay. Good. Shall we move on to the next? Which of the following is an example for prospective screening? What is the answer? Okay. Next topic is from types of screening. We have two types of screening. One is prescriptive. We have two types. Screening are of two types. Wait. Screening are of two types. One is prescriptive screening. prescriptive screening and the next is prospective screening. That is the first MCQ. We have two types. One is prescriptive and the other is prospective screening. Now, what is prescriptive? As the name indicates, prescriptive means you're prescribing medicines to patients for patients on good, right? So, as the name indicates, prescriptive is done for the patient's benefit. Whereas prospective, what do you mean by word meaning prospective? Nothing to mug up. Prospective means looking into the future, right? That means for the future benefit of the community. So prescriptive means for the patient. This is for the patient. Prospective is for the community. So what is the answer? What is the answer? I'm not saying the answer. See, I said prescriptive means, do you want me to repeat? Do you want me to repeat? See, there are two types of screening. One is prescriptive and the next is prospective. Prescriptive means, as the name indicates, like you are prescribing medicines. Prescriptive means you are writing prescription for the patient's benefit. So prescriptive screening is done for the patient's benefit. Prospective means, you're looking into the future benefit of the whole community. So which one is the answer? Answer is screening of immigrants, right? See, cervical pap smear is for the lady. Neonatal screening is for the baby. Screening of urine sugar again is for the patient. Whereas screening of immigrants in a country is for the benefit of the whole community. Am I clear? Okay. Next is, okay, Shubhjit. Good. Moving on to the next question. I hope you guys are following. Okay. Human Developmental Index is measured by all except. What is the answer? Now the typical question. HDI and there are two terms. Okay. Human Developmental Index and PQLI. Okay. So you have let's see PQLI and HDI. This table is an MCQ. Each and every cell in this table is an MCQ. So let's see. If you want, you can take a picture of this table. There are two terms from which you can always expect MCQs. One is PQLI and the next is HDI. Now, what do you mean by PQLI? First MCQ. PQLI means Physical Quality of Life Index. Physical Quality of Life Index. HDI means Human Developmental Index. That was the question. Okay. PQLI or Physical Quality of Life Index means, listen carefully. Physical Quality of Life Index means, as the name indicates, you are trying to find the quality of life of people residing in a country. And if you want to know the quality of life of people residing in a country, three important factors or components which determine the quality of life of people in that country are IMR of that country. That means infant mortality rate of that country, literacy rate of that country, and life expectancy at 1 year of that country. Is it clear? Next is Human Developmental Index. Now, what do you mean by HDI? As the name indicates, Human Developmental Index means, as the name indicates, here you are trying to find out the development of a country. And if you want to find out the development, the most important factor is money, right? So, in development, the three important, if you want to know the development of a country, three important factors that you need to calculate are knowledge, income of that country, and life expectancy at birth of that country. Okay. Now, I can give you a mnemonic to remember this PQLI and HDI. PQLI you can remember as IL. See, it is LI. Okay, so it is again starting with the same IL. IL and HDI you can remember as kill. What is IL? IMR, literacy rate, and life expectancy. Kill is knowledge, income, and life expectancy at birth. Again, you can have a confusion, right? Because, life expectancy is coming under both. So, you can have a confusion like whether life expectancy at 1 year, is it coming under PQLI or HDI? Again, there is no need for any confusion because what is IMR? Infant mortality rate. Now, what do you mean by infancy? 0 to 1 year. So, the life expectancy up to 1 year is already counted under IMR. Are you understanding? That is the logic. So, there you start counting from next year onwards, from 1 year onwards. Whereas, I in HDI is not IMR but income. So, there you start counting from birth onwards. Is that clear? So, just remember PQLI is ill and HDI is kill. Are you with me till here? Next MCQ. Range is also an MCQ. When you compare PQLI and HDI, which one has long or which one has got more letters? PQLI 4 letters, HDI 3 letters, right? So the one which has more letters or the one which is lengthy has got a lengthy range, that is 0 to 100. Are you understanding? These are simple things which I am telling you to, you should be able to recollect it when it comes to the exam. Okay. So 0 to 100, whereas HDI 0 to 1. Each of this is an MCQ. HDI is short, so it's at birth. Yeah, even that way also you can remember. That's right. Okay. Whereas PQLI is long, so you are starting from 1 year. Okay. Good. Shubhajit, thank you for that alternate mnemonic. Good. So each of this is an MCQ, guys. Shall I move on to the next? So here the answer is HDI at birth. Okay. That is not there. Shall I move on to the next? All statement about quarantine are true, except. What is the answer? Even if you don't know the options, we know that quarantine and isolation are different, right? So the answer is it is synonymous with isolation. No, it is not synonymous with isolation. Now let's see the next MCQ or the set of MCQs regarding difference between isolation and quarantine. Now first, isolation is for the diseased person. Okay, isolation is for the deceased person. Don't you guys know that? See, after COVID, you should be very, very clear about the difference between isolation and quarantine, right? You advise quarantine for, isolation is for diseased person. Whereas quarantine is for the contact. It is for the contacts, right? Or apparently healthy individuals. Now, in isolation, what are you trying to do? You are trying to physically separate. You are physically separating the diseased individual, right? You are physically separating the diseased individual. Now, when you do that, what is your intention? Your intention is that this diseased person should not give disease to another person, right? So my question is, how long you have to physically separate that person? Till he can give disease to another person. What do you call that as? Period of infectivity. Okay, so isolation is done for the longest period of communicability or infectivity. For the longest period of communicability or infectivity. Whereas quarantine is done for contacts, right? Okay, like for example, suppose what to say? Okay, let's take the case of COVID itself. Someone is exposed to COVID and you are asking them to remain in quarantine, right? Because you suspect that they might be harboring the virus in their body and you want to confirm. So, till you confirm, you are asking them not to come out and mix with the public. So, it's not physical separation, but you are restricting their freedom of movement, right? You are restricting their freedom of movement. You're asking them to sit at home and not to go out and do social interaction, right? So, your intention is to confirm whether he has the disease or not, right? So, that means he has a virus inside his body or not. So, if that is your intention, how long you should wait? You have to wait till the longest incubation period, right? That means even after waiting for the longest incubation period, if the patient is not developing the disease, that means he doesn't have the virus in the body. So afterwards, you can ask him to, you can free him out of his quarantine and you can ask him to go and mix with the public. That's not a problem. Are you understanding? Is it clear? So each of this is an MCQ. There are 6 MCQs, guys. There are 6 MCQs in this table. 6 MCQs. Okay. Each of this cell you can expect as an MCQ. The difference between isolation and quarantine. Are you with me? Okay. Yes, Vishal, you're right. Good. Moving on to the next one. 14th question. Residents of 3 villages with 3 different types of water supply were asked to participate in a survey to identify cholera carriers. Because several cholera deaths had occurred in the recent past, virtually everyone present at the time submitted to examination. The proportion of residents in each village who were carriers were computed and compared. Classify this disease. Very, very simple, direct question. Tell me, what is the answer? What is the answer? I'm sure you will answer it correctly. See, what is the question actually? There is a outbreak of cholera, and when there is an outbreak of cholera, someone did a survey in 3 nearby villages to find out the percentage of cholera carriers. So survey is an example for, this is a question from study design. Survey is an example for cross-sectional study, right? So the best example for, this is a question from study design. Okay. And whenever you see survey, survey is an example for cross-sectional study. And when you do a survey, you will get the percentage of diseased people per 1,000 or per 10,000. So the next MCQ is, from cross-sectional study, you get prevalence. So you get prevalence from cross-sectional study. That is the next MCQ. Is that clear? You get prevalence. That means when you're doing a cross-section or when you're doing a survey, you're trying to find out what percentage of diseased are there per 1,000 or per 10,000 or per 1 lakh people in that area. Is that clear? So both these are MCQs. Good. Nadia, where were you till now? Nadia Shah. I'm seeing your name now only. Okay. Shall we move on to the next? Cross-section over. Moving on to the next important study design. A study which began in 1965, a group of 3,000 adults in Baltimore were asked about alcohol consumption. The occurrence of cancer was studied in this group between 1981 and 1995, which is the study design. What is the answer? The answer is? Any idea? I'm not seeing answer. Are you writing? Are you trying to write? There are 19. At least one person. Yes, Vishal. You're right. Okay. So, let's see. We are done with the MCQs from cross-sectional. The next 2 important study designs are case control and cohort. Okay. So, here, it's not a, definitely this is not a cross-section study. Now, let's see case control and cohort. First MCQ. I'm going MCQ wise. Both these are, first MCQ, both these are analytical study design. That is the first MCQ. Both these are analytical study design. Second, analytical means there is an exposure and there is an outcome. There is an exposure and there is an outcome. As in the case of this particular question, you have, which is exposure here? Alcohol, right? Alcohol. And outcome is malignancy, right? Cancer. Some cancer. We don't know. Some cancer. Okay, so you have an exposure and outcome. So in both case control and cohort, you have an exposure and outcome. Then what is the difference between case control and cohort? The direction in which you do the study is different. In case control, as the name indicates, you are starting with cases and controls. What do you mean by cases? Deceased. Okay, so in case control, you are starting with the deceased. Okay, you're starting with deceased and non-deceased. And you are retrospectively asking them about their alcohol consumption, or you're retrospectively assessing their exposure. That is case control. See, there is nothing to mug up. Case meaning is deceased, right? So as the name indicates, see why I say as the name indicates, because if you just look at that term, that itself is self-explanatory. You don't have to study at all. No need to mug up. As the name indicates, cases and controls. That is how you start the disease. You start case control. You're starting with diseased and non-diseased, and you're retrospectively assessing their alcohol consumption. That means what percentage of disease had taken alcohol and what percentage of non-disease has taken alcohol. Okay. Whereas, so that is case control. Whereas in cohort, you are doing it just the opposite. Cohort means word meaning. As the name indicates, cohort means a group having similar exposure. So you are starting with exposed and non-exposed. Then you are prospectively following them to see what percentage of your exposed will develop disease at the end of your follow-up time and what percentage of your non-exposed will develop disease at the end of your follow-up time. Okay, so that is cohort. So in cohort, you are starting with the exposed and non-exposed, and you are trying to find out the percentage of disease as the outcome. Okay, is it clear? Next MCQ, which is retrospective here. Retrospective means you're asking about something which happened in the past. So retrospective is case control. That is the next MCQ. Case control is retrospective. Next MCQ, which is prospective. Prospective means into the future. So in which one you are going into the future to see number of disease. That is cohort. So this is prospective study design. All these are MCQs. Is it clear? Okay. I think I'm writing small, but still you can see, right? Are you able to see? Is it okay? However I try, it is coming as small only. I'll try to write big. So here the answer is concurrent cohort. Concurrent cohort means prospective. Moving on to the next. Okay, Vishal, Beneem, Sonu, Shubhjit, Nadia. Good. Moving on to the next. Incidence rate of lung cancer among smokers is 10 by 1000 and non-smokers is 1 by 1000. The extent to which lung cancer can be attributed to smoking is everything is good and visible. Thank you for that positive feedback. I was kind of, I was little bit perplexed, like whether you are seeing it properly or not. The extent to which lung cancer can be attributed to smoking is, the question is about attributable risk. The question is about attributable risk. Okay. First MCQ. Attributable risk is something that you get from a cohort study design. It is something that you get from a cohort study design. That is the first MCQ. Second MCQ. Attributable risk. See, you get incidence from cohort, right? Cohort means you are following someone and you're trying to find out the new cases which happens among your exposed and non-exposed. New cases means incidence, right? Don't you know that? I don't want to go into those details. You know that, right? Incidence means new cases. So naturally, new cases you get in cohort, right? Okay. So the formula is incidence among the exposed minus incidence among the non-exposed divided by incidence among the exposed. This is the next MCQ. Next MCQ. Okay. Now, let's see what is the answer here. Here, in this particular question, incidence among the exposed is given, incidence among non-exposed is given. Just substitute it. So, you will get it as 10 per 1000 minus 1 by 1000 divided by, again, 10 per 1000, you will get it as 90%. So, here the attributable risk is 90%. Next MCQ. What do you mean by attributable risk of 90%? What do you mean by attributable risk of 90%? That means 90% of lung cancer cases happening in smokers is because of smoking alone. By the way, attributable risk means out of total risk for a disease, which is because of more than one risk factor. If you take the case of lung cancer, we know that smoking is one important risk factor. Then asbestos exposure is another risk factor. Air pollution is a risk factor, right? There are multiple risk factors. And the lung cancer risk is, or the lung cancer is because of all these risk factors, right? So out of all these risk factors, what percentage is attributed by single risk factor alone is what you're trying to find out in a attributable risk. Okay. And when you study the attributable risk between smoking and lung cancer, you got it as 90%. That means 90% of lung cancer cases that you see among smokers is only because of smoking, or that 90% of risk is because of smoking alone. So how will you apply that in prevention? If you can make smokers, or if you can remove this habit of smoking from among smokers, you can prevent 90% of lung cancer cases which are likely to happen among smokers. Rest 10% is because of other risk factors. Are you understanding? So the answer is 90%. Sorry, it's 90%. Okay. The extent to which lung cancer can be attributed to smoking, that is nothing but attributable risk, is it not? That is what I told you. Hope it is clear. Yes, all of you are right. Shall I move on to the next? To investigate the effect of tobacco chewed on oral cancer, it was observed that 30 out of 50 patients were tobacco chewers as compared to 10 tobacco chewers out of 50 controls. The odds ratio of oral cancer with tobacco chewing is. So the question is about odds ratio. Okay. So we have seen that in a cohort study, in the previous one, we have seen that in a cohort study, you get outcome measures as incidence and attributable risk. So you have 4 outcome measures in a cohort study. One is incidence, second is relative risk, then attributable risk and population attributable risk. Just remember these names. You have incidence, relative risk, then attributable risk and population attributable risk. These are the 4 outcome measures that you get in a cohort study. Whereas in a case control, you get only one outcome, which is odds ratio. So first MCQ is odds ratio you get from case control. You get odds ratio. Is that clear? Now let's see how to calculate odds ratio. You have see, in this particular question, it is said that there are 50 deceased and 50 non-deceased, 50 cases and 50 controls. And the exposure is tobacco chewing. Out of these 50 cases, 30 were tobacco chewers, and out of these 50 controls, 10 were tobacco chewers. So you have to first construct a 2 into 2 table. Like this. See, you have 50. CD, don't you remember? CD, I've already told you. Along column, always write disease status. So we have 50 diseased, 50 non-diseased. Out of them, 30 were tobacco chewers, and out of this 50 controls, 10 were tobacco chewers. This is how you get a 2 to table. So naturally, it will be 30, 50 minus 30, 20, and 50 minus 10, you will get 40 here. Are you with me? Now, how to find out odds ratio? Next MCQ. Odds ratio is also known as cross product ratio. See, A, B, C, D. It is also known as cross product ratio because when you put a cross like this, the product is known as odds ratio. So the next MCQ, it is also known as cross product ratio. It is also known as cross product ratio. And what is the odds ratio? Cross product will be A, D by B, C. Is that clear? AD by BC. Okay. So, yes. So, how much will be AD by DC? BC? Yeah, I am already getting the answer. It is 6. So, the answer is 6. Next MCQ, shall I ask you? What do you mean by odds ratio of 6? What do you mean by odds ratio of 6? Next MCQ. We are only discussing MCQs here. That means smokers have 6 times more chance for... Sorry. Here it is not smokers, right? We were talking about tobacco chewers. Yes. Tobacco chewers have 6 times more chance for developing oral cancer than non-tobacco chewers, right? That means how much risk is more among exposed than the non-exposed to that particular disease. Are you with me? Okay. So, from case control, you get odds ratio, and from cohort, you get from cohort, we have already seen, you will get incidence, then relative risk, attributable risk, and population attributable risk. These are the 4 outcome measures in cohort. Whereas there is only one outcome measure in case control, which is odds ratio. All these are MCQs. Is that clear? Yes, you are right. You are right. That is what I'm going to say next. Odds ratio more than 1 means this exposure is a risk factor. If odds ratio is less than 1 means this exposure is a protective factor. It is a protective factor, as in the case of, say, vaccination. Okay, vaccination and COVID. Is it clear? Vaccination will have a protective effect on COVID. That means those who are vaccinated will be having less number of COVID cases. So, less than 1 means odds ratio, more than 1 means it is a risk factor. Odds ratio less than 1 means it is a protective factor. Odds ratio equal to 1 means there is no association. No association between this exposure and the outcome. Each of this is an MCQ. Okay. Yeah, same with relative risk. Only difference is that relative risk you get from cohort. So, odds ratio or relative risk, both these have got the same interpretation. Odds ratio or relative risk more than 1 means this exposure is a risk factor. Only difference is that relative risk you get from cohort and odds ratio you get from case control. Is it clear? Okay. Shall I move on to the next? I really want to explain a lot, but what to do? Time is less. The major purpose of random assignment in a clinical trial is to, I think we are running out of time, so let me just move on to the answer. So, next is about the study design. RCT. The answer is to reduce selection bias. Okay. Now, what is RCT? First MCQ full form is randomized controlled trial. These are usually drug trials. Okay, these are usually drug trials. Here what you do is you take a group of patients with one particular disease, you randomize them into 2 arms or 2 groups of almost equal size. One arm is known as treatment arm and the other is known as control arm. To the treatment arm, you give your drug of choice and to the control arm, you give placebo. Then you follow both the groups for a particular period of time to see what percentage got cured because of your drug and what percentage got cured because of placebo. And this difference is what you are comparing. Is it clear? This is RCT. This is the design of an RCT. Now, in RCT, the most important thing is it is randomized control trial, right? That means you are randomizing the patients into treatment arm and control arm. Randomization means, I'm not going into the details, it is a scientific or it's a statistical technique by which it will be decided to, or it's a method to decide. It's a scientific method to decide which all patients will go to treatment arm and which all patients will go to control arm. Okay, so the advantages, the researcher cannot, or the person who is doing the trial cannot decide who all will go to treatment arm and who all will go to control arm. If you can decide, the thing is, you will select patients to the treatment arm, those patients who are likely to give a favorable result into your treatment arm, right? So that in whatever inferior drug you give, you are going to get a result that is going to favor your research, right? Is it clear? So, you will be selecting to get a favorable result, which is known as selection bias. So, selection bias will be removed when you randomize. Okay. So, the advantage of randomization is selection bias will be removed. That is the answer. Is it clear? Okay. So, randomization is done to remove selection bias. You cannot decide who all will go to treatment arm and control arm. Instead, there is a scientific technique by which it will be decided on its own who will go to treatment arm and who will go to control arm. Are you with me? Okay. Next question from, again, RCT only. Intention to treat analysis is done in. See, in RCT, what you are doing is, actually these are drug trials, right? You are giving drug to your patients to treatment arm and to control arm, and you are asking them to come for a follow-up, right? So, when you really do this, in field what happens? A few patients will never ever come to or they will not return for follow-up. So the confusion is whether to include them or to exclude them in the final analysis. Okay, that means what to do with the dropouts is a confusion. In RCT, what you do is intention to treat analysis. Intention to treat analysis is done in RCT. And what is intention to treat analysis here? Dropouts. Dropouts means those who did not come for the follow-up. They are included in the final analysis. They are included in the final analysis. This is intention to treat analysis, which is done in an RCT. Both these are MCQs. Okay. Intention to treat analysis is done in RCT. That is the first MCQ. Next, in intention to treat analysis, dropouts are included. This is the second MCQ. Are you with me? Okay. Moving on to next MCQ. This is from trial. Maximum tolerated dose of a new drug is evaluated in. The answer is phase 1. Now let's see what are the MCQs from each of this. Phase 1, you know there are 4 phases. Phase 1 is to calculate the dosage of drug. That is the first MCQ. To calculate dosage. Dosage and safety, of course. Second MCQ. Phase 2 is to calculate, again, safety and efficacy. Is to know safety and efficacy of the drug. See, in phase 1, you are trying to find out how much is the dose needed for patients. In second, you want to know whether this dosage is efficacious or not. Okay. Now, phase 3, the MCQ is, these are RCT. So, here you are giving your new drug to a group of patients, to another arm, you are giving control or placebo. Okay. And phase 4 is, the MCQ is post-marketing surveillance. See, after RCT, what you do is, once you feel that your drug is better, it is better, then you will send the results of an RCT to FDA. Okay. And FDA, after going through your phase 1, phase 2, phase 3 result, if they feel that this drug is good, they give permission to give it to patients. And once phase 3 is over, then you start marketing the drug. Is that clear? Then once you market the drug, starts post-marketing surveillance. So you are marketing after phase 3 and then starts post-marketing surveillance. This is the MCQ, or I would say these are the MCQs from each of these phases. Are you with me? Yes. Yes, Vishal, you're right. Sikandar. Good. All of you are right. Okay. So we have done with 20 questions from epidemiology and screening. Moving on to day 2. Are you with me till here? I would like to hear from you. Yes, phase 2 is efficacy. There are 25 and nobody is responding. We are done with day 1 question answers. Are you ready for the next? Next are very simple actually. We have 4 topics. Demography, family planning, MCH and nutrition. Okay, yes. Shubhjit, Sikandar. Yes, with just 2. Med Psycho. My God. What a name, man. Med Psycho. You mean to say all who are studying medicine will once become psycho? Arun, Chuck, Arun, Lord was Nadia. Okay. Hi, Lord. Okay, moving on to the next. In calculating dependency ratio, this is from demography. In calculating dependency ratio, numerator is expressed as present, ma'am. Okay. Like you're sitting in a class, right? Present, ma'am. In calculating dependency ratio, numerator is expressed as, what is the answer? So next topic is, I think rather than waiting for your answer, I hope you don't mind if I directly go to the discussion. The answer is C, dependency ratio. Yes. No, Nadia. No, Nadia. You, oh, Vishal. No. Sikandar. That used to be the answer earlier, but not anymore. Okay. Wait. Oh my God, all of you are wrong. Come on, stop. It's not B. Huh? Let's see what is dependency ratio. Now, what is dependency ratio? As the name indicates, dependency ratio means you want to know how many dependents are there. Okay, how many dependents are there in a country? By the way, what do you mean by ratio? Ratio means you have a numerator and denominator, and numerator and denominator are two different things. So in numerator, you have all the dependents, and in the denominator, you have all the independents. Are you with me? So numerator, dependence, independence. Sorry, denominator, independence. Okay. And we know that you take any country, a small proportion is always dependent on the so-called economically productive age group. There are two groups. Which are they? You have small children and elderly. And young age dependents are children less than 15 years. And old age dependents are above 65 years. 65 and above are old age dependents. Are you with me? It was 60 earlier. I agree, but not anymore. See, now doctors can be in service up till 65 years, right? Just remember. After that only, you are retiring. So up till 65, you are fully independent. Are you understanding? So it's not 60. Time is changing, guys. Time is changing. It's not 60 anymore, 65. After that only, that means till 65, you are economically productive. Yes. So this is dependency ratio. The formula of dependency ratio is the next MCQ. So you have in the numerator 0 to 14 plus 65 and above. In the denominator, it's not 100. That is the next point that I want to tell you. It's not 100, but all the independents, because it is a ratio, right? Ratio means numerator is not a part of denominator. So you have 15 to 64. Each of this is an MCQ. Numerator, denominator, and the numbers. All these are MCQs. No need to say sorry. We learn from mistakes, right? It's always good when you're committing mistake. I take it as positive because unless you commit mistakes, you will not learn. So be happy, Lord, that you have committed a mistake now. True about late expanding stage of demographic cycle is, another very, very important topic. Here I'm not waiting for your answer because I have some important topic, a very important topic from which you will get a lot of MCQs. That is from, here the answer is C. Okay. DRS, death rate declines still further and birth rate tends to fall. We'll see what it is and how this is the answer. So the next topic is demographic cycle. Very, very important. Okay. Now, what is demographic cycle? Just listen. See, you take any population, you take any country, whether it is developed or developing country or whatever it is, every country will have to pass through certain stages in its demographic evolution, which are mainly 5 in number. And all these 5 together is known as, it's a cycle. Okay, you call it as demographic cycle. Okay, next MCQ. Which are those 5 stages in demographic cycle? I said 5 stages. Stage 1 is high stage. These names are MCQs. That is the first MCQ. You have high stationary. Second stage is early expanding. Third stage is late expanding. Fourth stage is low stationary. And 5 is declining. Okay. So these are the 5 stages. And next MCQ. Each of the stage is described based on the shape of dash. Each of this is described based on the shape of demographic gap. Demographic gap. So that brings you to the next question. What is demographic gap? Okay. Now, demographic gap means it is the difference between birth and death. When you plot both birth and death on the same graph. See, you have a graph, right? Graph means you have a y-axis and you have an x-axis. Along the x-axis, you have time in, say, years. And along the y-axis, you are plotting both. Let me take another color. You are plotting both birth rate and death rate. Okay, then this gap you have between birth and death is known as demographic gap. This is known as demographic gap. Okay, and I said each of this is explained based on the shape of demographic gap. Are you with me till here? Are you with me till here? Okay, now let's see how are these explained. Very important, guys. I want your complete listening for the next few seconds. Few seconds only. Okay. Are you able to see? I'm going to show you using my hands. How are these stages explained? Okay, let me keep it down. My pen down. Can you see? I'm just waiting to see. Yes, yes. See, what is stage 1? Stage 1 was in pre-industrial era. In pre-industrial era, see, this is just imagine that this is your y-axis, this is birth rate, and this is death rate. Okay, and this gap is demographic gap. Now, using this, I'm going to tell you each of the stage, how it is explained. Okay, I said stage 1 was in pre-industrial era. In pre-industrial era, what was happening? Death rate was very high. Birth rate was also very high. Okay, birth rate, death rate, both were very high, but the number of births and deaths were almost equal in number. So what is happening to the gap? It is stationary, but at a higher rate. This is high stationary. Okay. Now, what is stage 2? Stage 2 was in early industrial era. In early industrial era, what happened? New medicines were discovered. New hospitals opened up. Environmental sanitation improved. Number of communicable diseases came down. As a result of which, the death also started coming down with birth going as such. So what is happening to the gap? Birth is going as such, but death is coming down. So gap is expanding. This is early expanding phase. Right? Now what is stage 3? Stage 3 was in industrial era. In industrial era, what happened? Family planning was introduced. Okay, so people started using contraceptives. As a result of which, what happened? Number of births also started coming down with further decrease in death rate. That was the question. Okay, birth coming down with further decrease in death rate. This is late expanding. Okay, now what is stage 4? Stage 4 was in post-industrial era. In post-industrial era, number of births were less. Number of deaths were also less. But the number of births and deaths were almost equal in number. So what is happening to the gap? It is stationary, but at a lower rate. This is low stationary. Okay. Now what is stage 5? See, we know that however you try, you cannot bring, you cannot decrease the number of deaths beyond a limit. Do you agree with me? Because, at every second, a lot of people are dying, right? That means it is never ever possible to make death rate 0. Do you agree with me? But that is not the case with birth rate. You can bring any number of decrease in birth rate and you can even take it up to 0. That is possible, right? And this is what is happening in declining phase. In declining phase, death rate is going as such without any dip, whereas the birth rate is going beyond that. That means more people are dying than being born. So what will happen? The population starts declining. There will be decrease in number of population. So this is what is happening in declining. I hope you are with me. Are you with me? Have you followed till here? So this is your stage 1, birth and death high. Stage 2, stage 3, stage 4. I don't have a picture of stage 5, but I think you can guess what is happening. Death going, see, birth going below death. Are you with me till here? Please tell me. Did you follow till here? Guys, this is very important. Did you follow till here? I'm waiting for your S because this is very important topic. Say something. Yes or no? Yes. Sonu. Sonu Kumar Yadav. Shubjit. Yes. Honestly tell me, guys. Have you understood? We discussed a lot of MCQs from this. What is demographic gap? Then, what is stage 1, stage 2, stage 3, stage 4, stage 5? What is actually happening? It all those things. Medicos. Okay. Medico, psycho. It's yes with all. Okay. Then moving on to the next one. All of the following can be used as an emergency contraceptive measure, except this is from family planning. Crystal clear. Oh, okay. Now I am convinced that you have understood. All the following can be used as an emergency contraceptive measure, except, like I said, I am not waiting for your answer. So next topic is emergency contraceptive. The answer here is female condoms. Okay. So next topic is emergency contraceptives. First question, what is emergency contraceptive? Emergency contraceptive, what is the word meaning emergency? Emergency means what? You put that light, right? Beep, 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 beep sound. Emergency means you have to reach there within a limited time. Is it not? So emergency means it should be done within a limited time. So it is, as the name indicates, here the contraceptive should be taken within, what is that limited time? Within 72 hours. So usually done after unprotected sex, and you have to use it within 72 hours. This tablets should be taken, or whatever. This contraception should be done within 72 hours. That is why you call it as emergency. Okay. Now let's see which are the emergency contraceptive measures. There are 5 in number. These names are the next MCQs. There are 5 emergency contraceptive measures. First one, use Panlan's method. I'll tell you what it is. Second is mini pills. Third is high dose estrogen. Fourth is anti-progestogen, also known as mifepristone, RE486. Fifth is IUD insertion. Okay. These 5 names are emergency contraception, MCQ. Next MCQ. Out of this, only 3 are important for your exam. 1, 2, and 5. Okay. So let's start with the first one. Use Panlan's method. What is it? OCP that you are normally consuming at the time of emergency or after an unprotected sex, you have to take it in high doses. Next MCQ, what is the dose? This is normal OCP and the dose is 4 plus 4. That is the regimen. That is the next MCQ. That means you have to take 4 immediately followed by another 4 tablets. That means 4 tablets immediately followed by another 4 tablets after 12 hours. So the gap should be 12 hours and the whole should be completed within 72 hours. Hope I'm clear. I really want to explain, but due to lack of time, I'm trying to limit my words. Okay, so 4 plus 4 is the regimen. That is the next MCQ. Okay, next mini pill. Now let's see what is the MCQ from mini pill. Mini pill means progesterone only pill. Okay, OCP has both estrogen and progesterone, right? This is progesterone only pill. Next MCQ. Doses 1.5 milligram levonorgestrel. Just 1 tablet of 1.5 milligram levonorgestrel. Earlier there used to be 2 tablets. That is why I am specifying. Now you have only 1 tablet of 1.5 milligram. Okay. And it should be consumed within 72 hours. I'm not writing it anymore. It should be consumed within 72 hours. Next MCQ from mini pill. This is the drug of choice for emergency contraception. I said there are 5, but the drug of choice for emergency contraception is mini pill. Okay. Okay, Arun. Honestly speaking, yes. I trust you guys. Okay. Next MCQ. I said 3 and 4 are not important. Next MCQ is 1, 2, 3 and 4 I said should be taken within 72 hours. Right? Whereas IUD can be put within 5 days. That is the next MCQ. There is an advantage for IUD insertion. Here, you can use IUD as an emergency contraceptive for 5 days postcoital. Is that clear? See, all others should be taken within 72 hours. Whereas, suppose a patient is coming to you on day 4, then you can't use 1, 2, 3, 4. Instead, you have to use IUD. Are you with me? So, that is the next MCQ. It should be used within 5 days. These are the only MCQs from emergency contraception. Okay, shall we move on to the next? Which IUCD acts for 10 years? I know you know the answer. I know you know the answer. It is, because this is a repeatedly asked question, it is copper T 380A. It acts for 10 years. Whereas your A, B and D are for 5 years. Most of the other ones are for 4 years. Sorry, 5 years. Now let's see the rest of the MCQs from IUCD. There are only 2 IUCDs that are currently available under family planning, which are copper T 380A. This is copper T 380A. And we have one more available currently, which is multi-load 375. Multi-load, or you can even see copper T. Doesn't matter. Copper T multi-load. This is 375. Okay, which is, this is a T-shaped one. This is a T-shaped one, whereas this is known as inverted U. Can you see? It's U which is inverted. This is known as inverted U shape. So currently we have 2 available under family planning, which is copper T 380 and multi-load. This is multi-load 375. Next MCQ. Copper T 380A is for 10 years, right? That we have seen. Whereas multi-load is for 5 years. That is the next MCQ. This is new, and all new things are important for the exam. Okay. Shall we move on to the next? Everybody has said C. I knew it, guys. I knew that you would definitely answer this as C. No one can go wrong here. Dringle, huh? Now I got a new participant, Dringle. Rao. Okay. Most cost-effective method of family planning is? What is the answer? Only one answer, which is vasectomy. Vasectomy is the most cost-effective method of family planning. Okay. Nothing more, nothing less. Shall I move on to the next? Additional daily energy requirement during the first 6 months of lactation is. This is from MCH. Additional daily requirement for the first 6 months of lactation is. Any answers? Yes, it is D. Sahil. Sahil, new participant. J. J. Is it A? For the first 6 months is, see, remember 6 and 6. 600 calorie. Okay, it is 600 calorie. Now let's see. Don't worry, it's easy. As I said, commit mistake now and you will learn it forever. We know that females, they have increased energy requirement during pregnancy and lactation, right? During pregnancy, the increased energy requirement is, these are latest guidelines. This is latest 2021 guideline. What is given in your books may be different. This is the latest guideline. For pregnancy, she is asked to take 350 calorie extra and 23 gram protein. Earlier it was 22 gram. That is why I'm saying this is latest, 23 gram of protein. And during lactation, lactation period is again divided into 0 to 6 months and 6 months to 12 years. What's important? The first 6 months. First 6 months is exclusive breastfeeding, right? That means the mother is feeding the baby only. Okay, baby is completely dependent on breast milk. So the mother has to, sit and feed the baby all the time. So there she needs a lot more energy, right? So she is asked to take almost double the calorie of what she is taking during pregnancy. So it is not 350 but 600 and 19 gram of protein. Protein is less because when child is inside the mother needs more protein. Child has to grow, whereas outside not that much protein is required. And for the next 6 months, what's important is that next 6 months you are starting the baby on complementary feeding, so the demand comes down, so the calorie requirement is also coming down. It is 520 30. Is that clear? There are 6 MCQs here. Yes, Vikrant, all of you are right. Do you want any? See, it's easy to remember. Since you guys are kind of confused, let me give you, see, first 6 months, remember, where is it? First 6 months, 6. Can you remember? See, 6 and 6. For the first 6 months, it is 600. 6 to 12, 520. 2 and 2. See, 2, 2. Here and there. 12 and 520. Are you understanding? Are you able to connect to what I am saying? So, 6 months, 600. 6 and 6. After 12 months, 520. Is it clear? Okay. Okay. 5 clean practices under strategies for elimination of neonatal tetanus include all except. What are these 5 clean practices actually? These 5 clean practices are for elimination of neonatal tetanus. Okay. So in neonatal tetanus elimination, which is not coming, clean airway is not there. The answer is D. I should have waited for your answer, right? So the answer is D. Now let's see which are these 5 clean practices. These are for elimination of neonatal tetanus, right? Okay. That is the first MCQ. 5 clean practices are for elimination of neonatal tetanus. Now listen carefully. See, as long as the child is inside the womb of the mother, child is safe, right? But the moment it decides to come out, we doctors and hospitals will be waiting outside to introduce neonatal tetanus to the baby. Am I exaggerating? No. Think logically. From where is child getting this infection? From us only, right? Right? That means there are 5 levels in which you are likely to introduce neonatal tetanus to the baby. And for preventing these 5 conditions, we have 5 cleans. Is that clear? Now, what is the first clean? See, the first clean starts in the second stage. In second stage, you are offering a delivery surface for the mother. If that delivery surface is not clean, it can give neonatal tetanus to the baby because, in stage 2, as you know, the membranes are ruptured and the cervix is fully dilated. So, if that surface is not clean, then Clostridium tetani can easily ascend and give infection to the baby, right? So, the first clean is clean surface. Now what? Now the baby is about to come out and we doctors are waiting outside with unclean hands. So the second clean is clean hands, right? Okay. Now there are 3 more cleans and these 3 cleans are with regard to cord cleanliness. So next is when you're cutting, use something sterile for cutting. Okay. Use some sterile blade or sterile scissors. And after that, when you're tying, use clean cord tie. But that's not a problem anymore because we have sterile clips, disposable clips, which are available. Plastic clips. Then keep the cord clean. That means stump should be kept clean because in some states they have the habit of applying cow dung, ashes, mud, which can give neonatal tetanus. Okay, so these are the 5 cleans. Are you with me? Now they have introduced 2 more cleans. Now it is known as 7 cleans. So we have 7 cleans now. That means along with this, we have clean. They have also introduced, means WHO has made it 7 cleans now, which is while washing hands. These are for doctors. These extra 2 cleans, to be very honest, are for doctors. Clean water. And after that, while drying, don't dry it on your apron. Instead, use clean towel. Are you with me? So 5 clean plus 2, you have 7 cleans now. Use clean water and clean towel. All these are MCQs. Have you followed till here? 5 and 7 cleans are for elimination of neonatal tetanus. Moving on to the next. As compared to cow's milk, human milk has. Okay, let me wait for your answer. I'm seeing the question here in YouTube. So you also must be seeing the question. Then why there is a delay in answering? What is the answer? Answer quickly. I'm feeling hungry. No, Lord. Oh Lord, that's not the answer. The answer is, I'll show you a comparison. See, when you're, guys, why are you taking out your answers? Don't remove the answer. Keep it there. Come on. When I say no, you're removing the answer. Don't do that. Okay. Yes, yes, yes. Let's see. Let's see. So no, shake. When you have removed their answer, I saw your answers. I'll show you a table. You don't need to remember the numbers. It's just a comparison between cow's milk and human milk. There are mainly two things which are more in human milk. Just two things. Which are they? One is lactose. See, lactose or carbohydrate. Lactose means carbohydrate. And iron. Can you see iron? Apart from lactose, carbohydrate, and little bit of water, of course. Okay, I'll say water. So you have only three things, I would say. Three things more in human milk. Which are they? One is carbohydrate or lactose, iron, and water. Except these three, all are more in cow's milk. Okay, just remember, it is lactose, iron, and water. Only these three are more in human milk. So the answer is more iron. Human milk has more iron. Is that clear? So only three things are more. One is carbohydrate or lactose, then iron and water. Recommended dose of folic acid during pregnancy is how much? I'm sure you know the answer. So there's no need to wait. What is it? The answer is, you know that, right? It is 500 microgram per day. Now I'll show you a table. See, this is the dose. This table, if you want, you can take a, yes, yes, your answer is right. If you want, you can take a picture of this table or a screenshot. If you are using a laptop, mobile, you can take a screenshot because this is very, very important table. Each of the cell is an MCQ. So, see, we are giving iron tablets as per our program, National Iron Plus Initiative. We are giving iron tablet to how many categories? 5 categories. That is the first MCQ. Which are those 5 categories? Of which 3 are children. Wait, let me take, it's already blue, so let me take a red color. Okay. Okay, sorry. Sorry. 2 are children. I said 5 categories, of which 2 are children, 2 are adult females, and 1 is, what you have in between is adolescent 10 to 19. So 10 to 19, first MCQ, 10 to 19 is known as adolescent age group. Now the frequently asked MCQ, 10 to 19. So children, again divided into 6 months to 5 years. Then you have 5 to 9 years. Then starts, it's like it's in that order. Then you have 10 to 19 years. Then 20 to 49. That means females in the reproductive age group. Then pregnant and lactating women. Is it clear? Okay. Now, I'll start with the first one. See, for children, 6 months to 5 years, you are giving 20 milligram of elemental iron and 100 microgram of folic acid. Is it clear? So, in the ratio 1 is to 5. Okay. So, you are giving 20 milligram of elemental iron and 100 microgram of folic acid up to 5 years. Is it clear? In the ratio 1 is to 5. In the second, 5 years to 9 years. So, you can remember 5 means minus 1, 4. You remember this number 4. It is 45 milligram of elemental iron and 400 microgram of folic acid. Is it clear? Okay. Now, from 10 years onwards, it's the same for everyone. 60 milligram of elemental iron and 500 microgram of folic acid. For 10 years onwards, only for children, there it is different. Whereas from adolescent till 49 years, it is 60 milligram of elemental iron and 500 microgram of folic acid. So nothing more to remember. Just remember this number 60 milligram. From 10 years onwards, 60 milligram of elemental iron and 500 microgram of folic acid. Okay. Now coming to frequency. For small children, it is given as liquid. It is given as in liquid formulation. So you have to give it twice weekly. Is it clear? For pregnant and lactating women, we already know. If you have worked in hospital or if you have done your internship, you know that it is, even otherwise we know that for women, pregnant women and lactating women, it is you are giving it daily, right? 180 days antenatal and 180 days postnatal. That is also an MCQ for how many days you are giving and how you are giving daily 180, 180. Is it clear? Whereas for all the rest, you are giving it weekly once. So for small children, it is bi-weekly. Starting and ending only, you have some change. Bi-weekly, here you are giving it daily. Whereas those who are coming in the middle, it is once weekly. Now, next MCQ, color of the tablet. For pregnant women and women in the reproductive age group, it is red. No doubt. For all females, it is red. Then, for small children, 5 to 9 years, others it is liquid. Here it is pink color. Whereas for adolescent, you remember it is blue. Neeli goli. Neeli goli, that is blue color. Is it clear? Okay. So each of this is an MCQ. Now if you are interested, you can take a picture. Never ever miss any of the thing that I have written in these cells. Shall I move on to the next? Okay. A community has a population of 10,000. CBR, what is CBR? Crude birth rate. CBR is crude birth rate of 36 per 1,000. 5 maternal deaths were reported in the current year. What is MMR? 5 maternal deaths, crude birth is given, and the question is to calculate MMR. First MCQ. What is it, Rao? Some OBG teachers say 400 microgram for pregnant women. No, yeah. No, it is 500 microgram. Okay, because we are giving, in the PHC, we are giving it. Okay, it is 500. In my original presentation, you will see the picture of not this one. I'm saying what is there in the app. In that, you will see in that presentation, I have given the picture of the tablet and all the contents. So it is 500 microgram. There is no doubt about it. Okay. And 4 milligram with history of, that is there. After neural tube defect, if a mother is having a baby with neural tube defect, that is true. You are giving 4 milligram. That is different scenario. What I'm talking to you is normal thing. Okay. Is it clear? Rao, Vineet? Okay. First MCQ. What is MMR? MMR full form is, if you're saying it as maternal mortality rate, it is wrong. It is not maternal mortality rate, but maternal mortality ratio. First MCQ. Full form of MMR is maternal mortality ratio. Ratio means numerator and denominator are different. So what is the formula? It is number of maternal deaths in the numerator divided by number of live births in the denominator per 1 lakh. Is that clear? Now what do you mean by this? This means when 1 lakh children are born alive into a population, how many mothers are dying or how many maternal deaths are happening? Am I clear? When 1 lakh children are born alive into a population, how many maternal deaths are happening? Okay. Next MCQ. This formula is an MCQ. Next MCQ. What do you mean by maternal death? Maternal death means a mother dying while she is pregnant or during. That means at the time of delivery or after delivery for how long? That is the next MCQ. After delivery for 42 days. This is the next MCQ. 42 days or 6 weeks. 42 days or 6 weeks. That means after delivery, the death up to 42 days or 6 weeks will also be considered as maternal death. But not from accidental or incidental cause. Means what? Suppose a pregnant woman, she's dying in an accident, in a road traffic accident. Can you call it as maternal death? No. Suppose she is committing suicide. Can you call it as maternal death? No. I hope the message is clear. This is very, very important because for your exam, you will be given a lot of data like 5 died in antepartum hemorrhage, 5 died in postpartum hemorrhage, 2 died in electrocution, 1 died in drowning. Calculate the maternal mortality ratio or what is the number of maternal deaths. Then you should know that drowning is not coming under maternal death. Electrocution is not coming under maternal death. Hope it's clear. Is it clear? Abigail. Where were you? I didn't see your name. Oh, you were there, no? Even before? Abigail. Very nice name. So, this is maternal death. Now, let's see how to calculate MMR. We are actually trying to discuss many MCQs from one question. That is why it's taking long time. Formula of maternal death is MMR is number of maternal death, which is clearly given as 5. And you have to calculate denominator dot number of live births, right? Now, how will you calculate live birth? That is not directly given. Instead, they have given crude birth rate, right? Crude birth rate means per 1,000 people, how many births occurred. Okay, per 1,000 people, how many births occurred? That is crude birth rate, which is given as, I forgot the number, yes, 36. That means per 1,000 people, 36 births, live births. And they have clearly said there are 10,000 people in that community. So, per 10,000 would be 36 divided by 1,000 into 10,000, you will get 360. That means 360 is the total number of live births per 10,000. Is it clear? Now, can't you calculate MMR? So, MMR is, it is usually calculated as per 1 lakh, but here it is given as 1,000. Okay. So, 5 divided by 360 into 1,000. So, we'll get it as 13.8 per 1,000. Is it clear? Is it clear? So, now you might be wondering why it is 1,000. See, there is only one reason for putting it as 1 lakh. It is given as 1 lakh. Okay. Because maternal death is something, we were earlier using 1,000 when lot of mothers were dying. But now the maternal death has come to so less number that if you go for per 1,000, the thing is you will be getting as 0.01 or 0.02. So to make it as a whole number, we have increased the multiplier to 1 lakh. That is the only reason. But whereas in this question, it is per 1,000 because maternal death is more. Is it clear? So it is 13.8. Hope it's clear. Okay, let me see. Yes. Okay. Next question. Perinatal mortality rate includes. What do you mean by peri? Peri meaning is in and around. Right? In and around. That is word meaning. Nothing to mark up. Peri means in and around. The natal means time of birth. So, it is around the time of birth. That means it includes few days before birth and few days after birth. Few days before birth is nothing but the time you consider as stillbirth. And few days after birth is nothing but the time you consider as early neonatal. Early neonatal means 0 to, that means first 1 week is early neonatal. It is early neonatal. Neonatal, sorry. Neonatal. Early neonatal. Okay. So, perinatal means in the numerator you have number of stillbirths as well as children who died in the early neonatal period. That means death within 7 days. Very simple. Peri means in and around. Perinatal means in and around the time of birth. That means it includes the deaths which happened before birth and immediately before birth and death which happened immediately after birth. So, immediately before birth is nothing but stillbirth. Is it not? Immediately after birth means immediate means 0 to 7 days. Okay. So, here the answer is A. Hope it's clear. Very, very simple. Okay. And the formula of perinatal mortality rate is number of perinatal deaths divided by not just live births but since you are calculating stillbirth as well in the denominator, you should also calculate stillbirths weighing more than 1000 gram. Weighing more than 1000 gram. So this is also an MCQ, the formula. Is numerator and denominator clear here? Okay. Yes, yes. Manoj, Raju, all of you are right. IMCI was taken to prevent morbidity and mortality from all except. First question, what is IMCI? Integrated Management of Childhood Illness. It will not include, what is the answer? Let me just see whether you will answer it correctly. I'll take that heart. Yes, Pavan. Okay, I got A, B, C, D all in the answer. So let's start. But answer is, we'll come to the answer. One of this is an answer. Okay. We'll see what is IMCI. Integrated, full form is, first MCQ, what is the full form? Integrated Management of Childhood Illness. So as the name indicates, here you are integrating. Integrating means bringing together, right? Management protocols of various childhood illness. Now, why are you doing that? Here, see, IMCI is in developing countries. It is mainly for the developing countries because we know that when you compare the number of deaths happening in developing countries with that of developed countries, we know that a lot more children are dying, especially the under 5 deaths are much more in developing countries than or compared to developed countries. And one reason for this increased number of under 5 death is because of, lack of timely diagnosis. Because we know that unless it is highly indicated, the parents will not take their children to hospitals. Moreover, diagnosing childhood illness is also difficult because children will be presenting with almost similar signs and symptoms. Malnutrition, sometimes the child will be crying, cough. So it's very difficult to find which is the actual diagnosis of disease unless you go for some high-five treatment, or I would say high-five diagnosis, which is difficult for developing countries. So as a solution for that, WHO introduced IMCI, Integrated Management of Childhood Illness. Here what they have done is, they first listed the major 5 childhood killers in under 5s. Then they listed their signs and symptoms. Then they combined them and made them into 3 different classes, and each class was given a color like this. Okay. So the first color is green. Second is yellow. Third color is pink. So as per the signs and symptoms, if the child is coming under green, that means child is safe and child can be managed at home. Yellow means child requires only OP treatment. Pink means, pink is a sober color of red, right? Red always means emergency. So here the child needs referral. Is it clear? Now, what is the advantage of IMCI? Now, this is somewhat like ARI control program, or it's like syndromic approach, right? Now, what is the advantage of syndromic approach? Advantage of syndromic approach is that if you can lightly train field workers, they themselves can pick the disease and they can do whatever is necessary, right? So, thereby you can prevent that, delay in timely diagnosis could be taken care of. Is it clear? Okay. Now, the question is, this is IMCI. Now, the question is, which are those 5 diseases coming under IMCI? Which are those 5 under 5 killers? You go to any hospital. If you have ever gone to pediatric ward, I would say 50% of children will be having either this or that. 50% of beds will be filled with children having diarrhea and respiratory infection, right? So these are the 2 major killers in developing countries. There are 3 more left, and these 3 starts with M. So which are they? Malaria, measles, and malnutrition. So these are the 5 diseases coming under IMCI. Okay. So the answer is tetanus is not there. Malaria, malnutrition, otitis media, all these are coming under. Otitis media is a complication of ARI, right? So it is coming under ARI. Is that clear? Am I clear? Moving on to the next. I think only 6 more questions. 6 more questions. Don't worry. What's the time? It's 7. Oh, definitely we'll stop before 7:30. I won't even go till 7:30. Don't worry. Deficit in weight for height in a 3-year-old child indicates. Still there are 25. Hanging on. Good. This is important, right? Deficit in weight for height in a 3-year-old child indicates. What is the answer? Just think. Height is good, but it is very reduced. What is it? Yes, Manoj. Correct. Acute malnutrition. Yes. Good, good, good. No, Pavan. I'll tell you what is chronic. Rao, Vineet, correct, correct. Good. It is acute malnutrition. Now let's see the MCQs from malnutrition. There are mainly 3 MCQs from malnutrition. 3 commonly asked MCQs from malnutrition. Shall I tell you? First is height is normal, but weight is reduced. That means low weight for height. Just imagine that you see someone who has normal height but very lean. What do you call that person as? Or that person looks somewhat like this, right? Somewhat like what you are seeing here. You call that person as emaciated, right? Suppose you see one of your friends who is dieting like this. What will you ask? Are you not eating for the last few days? Right? That means this appearance will be there if the person is not eating recently, right? So this is known as nutritional wasting or emaciated. That person looks wasted, and this will happen due to some recent reduction in food intake. So this is acute malnutrition. Are you understanding? This is very simple. Height is okay, normal, but weight is reduced. Acute malnutrition. Okay. Suppose the child has not eaten for long time, like from childhood the child is getting less food, then even the weight will be reduced, sorry, even the height will be reduced. So low height for age is known as stunting or dwarfing, and it is indicative of chronic malnutrition. Chronic will also affect height, whereas weight is affected first, that is acute, and the child will be looking like this. Third MCQ. Low weight for age, you call it as underweight. Age is okay, but weight is less. Low weight for age is known as underweight. This is what you are seeing in growth chart, right? Child is underweight is what you say. And underweight is common for both acute and chronic. Are you with me? That is next. It is common for both acute and chronic. Are you with me? Yes, Manoj. You're right. Shiva. Yes. I'm seeing Shiva now only. Chasing dreams. Ma'am, you can go as long as you want. We love listening to you, ma'am. Oh, thank you so much. But I have to stop, right? And we have only 40 questions. We are already done with, if you don't know, we are already done with 37 questions. Next question. ANM is responsible for registration of all pregnancies in her subcenter area. If the expected pregnancies in her area in a year are 100, how many should be registered approximately at any given point of time? Any idea? This is very simple. What is the answer? I think there is some delay. Is there any delay? I don't see the. Is there any delay? Please let me know. Please let me know. Is there any delay? I'm asking. Please let me know. Because I see my YouTube stuck here. Are you hearing me? Yes, there is a lag. There was a lag. That means, is it going normal now? Because in my YouTube video, I am stuck. That is what I am seeing. Shall I proceed anyway? Okay, this is a very important question. Start with the ANM. Okay, there is something known as 50 percentage rule. You can remember rule of 50 percentage. Rule of 50 percentage. That means it is said that, listen carefully. See, 50 percentage of total pregnancies in a year will be registered with the ANM in 1 month. 50 percentage of, it's going normal for me. Then it's fine. Maybe my problem. Sorry. 50 percentage of pregnancies will be registered with the ANM at 1 month or at one point. So if there are 100 pregnancies, that means half of that will be registered with ANM at any one point or in 1 month. In both way, you can get the question. In 1 month, how many will be registered? Then out of total, 50 percentage. At 1 point, 50 percentage. So the answer is 50 here. Is it clear? It got corrected automatically. Okay. Thank you, Lord. Weight of an Indian reference man in kilogram. This is a new question. Okay. Question is not new. Answer is new. Because previous answer is changed recently. It used to be 60. Now it is 65. Okay. There is a change. Please listen. There is a change in the previous values of Indian reference man and Indian reference woman. You know what is Indian? If you want to compare the height or weight or say the, our body weight with that of someone, we always require a standard, right? So that standard is Indian reference man and Indian reference woman. Now let's see. Lagging. Yes, Abigail. Even I felt it. I think it is lagging with with few. Anyway, trying to go fast. Indian reference man and Indian reference woman. What I'm going to show you next are the latest numbers. Indian reference man, ages, there is age, height, weight, and BMI. All these are MCQs. Ages 18 to 39. Previously, it was 18 to 29. Okay. Previously, it was 18 to 29. Now it is 18 to 39. That means after 40, you are considered as reference. Weight 65. Earlier it was 60. Now it is 65. Height 177 centimeter and BMI 20.75. Each of this is an MCQ. Age, weight, height, BMI. All these are MCQs. And this is the latest. Let me write latest. Now you will say, in that book, it was like this, madam, but you said this, they said something else. This is the latest. Okay. You might be reading the old one. This is the latest. Now let's see what are the guidelines for an Indian reference woman. Vikrant. See, same person giving two answers. This is cheating. For Indian reference woman, okay, I'll say, okay, you said 55 and 65. One is for male and the other is for female. Indian reference woman, age is the same, 18 to 39. Then weight, 55. So you can remember 65 and 55. Is that right, Vikrant? So you have given two answers. Both are correct. 55 is for female and 65 is for male. So remember 5. Both are ending with 5. Then height 162 centimeter and BMI 20.95. Usually they are not get question from height, BMI. What if they feel like asking, okay, this time we will ask height and BMI. So remember height and BMI as well, and these are the latest guidelines. Shall I move on to the next? 5 more questions left. Serial cell pulses are considered complementary since. You will answer this question, I know. Female 55. Yes. What is the answer? Cereals are deficient in? Answer is cereals are deficient in lysine and pulses are deficient in methionine. I still see lag. It's kind of disturbing when you see lag. Because I will be wondering whether you are actually listening or not. Okay. So the answer is A. Cereals are deficient in lysine and pulses are deficient in methionine. So the next topic that we are going to discuss is limiting amino acids. Limiting amino acids. First question. What is limiting amino acid? Limiting amino acid is if you are saying the acid or sorry the amino acid which is deficient, that is not the answer because a lot of amino acids will be deficient in protein. The ones which are most deficient are known as limiting amino acid. Okay, not any amino acid but essential amino acid which is most deficient is known as limiting amino. The MCQs are in cereals. It is threonine and lysine. It is threonine and lysine. If you want, I can give you a mnemonic. The mnemonic is TLC. That means T and L are deficient in C. TLC. T and L are deficient in C. What is TLC? TLC could be anything, right? It could be total leukocyte count or tender love and care. It could be anything, right? So T and L are deficient in C. Next is pulses are deficient in cysteine and methionine. So you can remember the mnemonic, a very simple mnemonic, PCM. That means P is deficient in C and M. By the way, what is PCM? How do you write paracetamol? How do you write paracetamol? Tab PCM, right? That is how we write paracetamol. Or you can remember PCM as physics, chemistry, maths, or whatever. Okay. Huh. Just something came up to my mind now. When I was asking about TLC in class, there was a there was one student who was a big fan of WWE. So he told me tables, ladders, and chairs. That is the first time I got that mnemonic: tables, ladders, and chairs for TLC. Okay, can hear you, but the video is stuck. Is that? Oh, I see. I see. Okay, Anand, LTMT, essential. Okay, all of you are right. Exactly. Exactly, Lord. Then maize is deficient in lysine and tryptophan. You can remember MLT. You know what is MLT? Yeah, medical lab technician. It's a course. So this is an MCQ. This is also an MCQ. This is also an MCQ. Is that clear? Moving on to now okay. Now we have 17, 18, 19, 20. 4 more. Which of the vitamin deficiency occurs in maize eating population? Don't you know the answer? Yes, you know the answer. And if I wait, you will correctly answer. It is Pellagra, right? So first MCQ, Pellagra is seen in, what is Pellagra? It is due to deficiency of niacin. It is niacin deficiency. Second MCQ, it is seen in which are conditions? It is seen mainly in maize eating population. Maize eating population or jover. That also was a previous MCQ. Jover eating population. Okay. Third MCQ. Is there any disease which can cause pellagra or niacin deficiency? Yes, it is INH. So those patients who are on INH can also develop pellagra. That is exactly why we are giving, we are giving pyridoxine tablet. Okay. So each of this is an MCQ. Okay. Moving on to next. Okay. Thank you, Lord. Such a support, man. Seriously, it really boosts up it really boosts the teacher who is taking the class. Which of the following will cause letharism? It is Kesari dal. If I had waited, I know you would have correctly answered. It is Kesari dal. Kesari dal. Now let's see. Next topic is food toxicants. Food toxicants. Let's see which are the important food toxicants. That is the next MCQ we are going to discuss. We'll start with letharism only. Yes, 4Ds, acid deficiency, right? Diarrhea, dermatitis, you know that, right? Dementia, death. I thought would discuss that, but since we are running out of time, I purposefully omitted that 4Ds. Since you have brought it up, 4Ds are seen in niacin deficiency or pellagra. Now, food toxicants, what you see here is dal, right? So, one is actually normal moong dal and the other is kesari dal. They look so similar, that is why they get easily mixed up. So, letharism is caused by the toxic principle that is present in kesari dal, BOAA. What is BOAA? Beta oxalate amino alanine. That is the next MCQ. This is an MCQ. This is also an MCQ. Okay. Next. You all know about kesari dal and letharism. Next question is, then what is epidemic dropsy? Epidemic dropsy. Easy to remember. See, dropsy means drops. Just remember this term, drops. Drops are caused by two things. Which are they? One is water and the next is oil. So, remember water and oil with regard to epidemic dropsy. So, epidemic dropsy is caused by an oil. Which oil? Argemone oil, which contain sanguinary. It is caused by argemone oil, which easily get mixed up with mustard oil, and it contains sanguinary. Now coming to water part. Next MCQ from epidemic dropsy part. It is the manifestations are mainly that of water retention. Like what you see here is this picture is argemone flower, argemone mexicana, from which you get argemone oil. And the second MCQ is, I hope you can see it now, from water. Water, the answer is, or the MCQ that you have to remember with regard to water is, the manifestation is like endemic ascites is starting with A. So here it is because of an alkaloid, which is A and A. It is because of an alkaloid which is present in crotulary acid, and the name of the alkaloid is pyrolysidine alkaloid. That is the MCQ. And what about the manifestation? Of course, it is a hepatotoxic thing. That is why ascites. So naturally, the manifestation will be in the form of ascites. Is it clear? So remember, we have kesari dal causing letharism, BOAA, BOAA. Dropsy, sanguinary, that means argemone oil, which contains sanguinary and water retention. Then endemic ascites, A, pyrolysidine alkaloid. Moving on to it's 19th question. That means we have one more. Under ICDS, supplementary nutrition for children below 5 years of age is aimed at providing exactly loss of albumin. Ajay, it's showing us loading. I can't see anything. What you have posted under ICDS. So let's start with the first MCQ from ICDS. Here the answer is 500 calorie and 12 to 15 gram protein. ICDS first MCQ. Full form is Integrated Child Development Services. Okay. Second MCQ. This is the logo of ICDS. In ICDS, you will get the baby on the lap. Okay. Because ICDS works through Anganwadi. Don't you know that? And in Anganwadi, we are mainly providing benefits or services to mothers and children. So, you see mother and a child on the lap. That is ICDS. And next MCQ. One Anganwadi is for, if you're saying 1000, it's wrong. It's not for 1000 anymore. One Anganwadi is for, this is a revised norm, 400 to 800 population. That is also an MCQ. Thereafter, it is for multiples of 800. So, this plus 800. For 2 Anganwadi, 800 to 1600. 3 Anganwadi, 1600 to 2400. That is how it, increases. Then plus 800 plus 800 plus 800 like that. Okay. Then, oh, what happened to my, wait. I lost my YouTube once again. Okay. Okay. Then, next MCQ. Who are the beneficiaries coming under? Just remember, when it comes to children, the question was about the child nutrition. When it comes to child nutrition, we have mainly three types of, you have to remember three beneficiaries. Okay. Children 6 months to 6 years. Then, pregnant and lactating women. And then, malnourished children. Okay. So, for children 6 months to 6 years, you are giving 500 calories and 12 to 15 gram of protein. Whereas for 800 when it comes to, so this is number one. In same order, you have to remember 500, 600, 800. Then protein, you can remember like 15, 15 gram, 20 gram, 25 gram. So for the first group, you are giving 500 kilocalorie and 15 gram. So 500, 600, 800, then 15, 20, 25. Are you following? Is it clear? So this way you can remember 6 months to 6 years, pregnant lactating women, malnourished children, 500, 600, 800 and 15, 20, 25 gram. And moving on to the last one, ICDS requirement is. This question comes almost every year. It's a very simple question, but you should be knowing. ICDS requirement is, we are giving them food, supplementary nutrition, right? That is to supplement 1/3 of calorie and half the protein. So we are expecting that the food that we are giving to children will take care of 1/3 of their daily calorie requirement and half of their protein requirement. Okay. And ICDS, this is the next MCQ. There are 300 feeding days in a year and the supplementary nutrition will take care of, this was the MCQ, 1/3 of the calorie and half the protein requirements. Okay. So that finishes 6 topics for today. Okay, tell me, was it useful? Say something, was it useful? I think there is a lag, but I really want to hear at the end from you people whether you have understood or was it too, I mean, apart from the, the glitches, technical glitches, which I can't do anything. Apart from that, was it useful? Yes, Lord. You're welcome always. Yes, it is coming under midday meal program. Thank you. Thank you. It's always nice to hear that you have understood the session because after all, we are putting in a lot of effort. If it has correctly reached you, it will be a blessing for me. Okay. Okay. So I hope you have understood. And we have one more session left where I'll be discussing paper 3 and paper 4. Useful. Okay. Okay. So happy to know that. So keep in touch. Bye. And very soon I'll be coming once again with paper 3 and paper 4. So shall we call it a day? Amit. Okay. Amit. Okay. Hereafter I will not call loud. Amit. Thank you, Amit. So guys, Anything else? If you have any doubt, I'm here. You can ask me. Do you want my number? If you want, I can give you my number, my WhatsApp number. So that you can get in touch with me. If you want, I can give you my WhatsApp number. Do you want WhatsApp number? If you say yes, then I'll write. Just in case you don't require, why should I be writing it unnecessarily? Because you have my Telegram ID, you are in touch with me through Facebook and also just wanted to know whether you want my number. Okay. Okay, then I'll write my WhatsApp number. This is my WhatsApp number 9895449210. Okay, if you have any doubt, you can ask me. Honestly, let me tell you, I may not be able to give you a timely reply, but within definitely, within one day, I'll be getting back to you. Okay. So bye. Good night. Good night. So I'm going to stop streaming.